As usual, another great guest, but a quick diversion. You'll notice that our full name is the Marketplace for Health, Wealth, and Freedom. Well, let's talk about your health for a moment. If you'd like to escape from the stranglehold of insurance and be able to see alternative doctors or go across state lines for care, then you definitely need to take a look at patientempowerment.mpb.health and see if that's the fix you've been looking for. Now, let's get back to the show.
Welcome, folks, to Freedom Hub's Health, Business, and Politics weekly webinar. I'm Charlie Froman, and my co-host is Jim Graypeck, creator of The Pavilion, the next generation in integrated primary care, and a whole lot of other stuff. And today's guest, Dr. Friedberg, is going to be very interesting because all of us are nervous when we're told by our specialist that we need surgery. And I don't know about you guys, but I've had 5 of them in my life of 55 years. And what I learned in learning about Dr. Friedberg is that there's some side effect worries from the drugs they use to make sure you're under and don't really experience anything during the experience of surgery. The surgeon knows you're not going to react to any pain. It's done, you wake up, and then it's recovery time. But Dr. Friedberg's venture is about Goldilocks anesthesia. Just like the story, finding the right temperature of oatmeal or the right size bed, is about finding the right amount of medicine to put you under without hurting you. And he uses, I guess, what's called propofol ketamine, and I'm sure he'll correct my pronunciation and explain it. If you read the write-up for today, you know, I find it fascinating. Think about the terror of surgery up until 100 years ago. We know from the opioid crisis about the power and importance of the poppy plant for pain relief since the 1,000 years ago in Egypt. And then in the 1600s, I guess they started using variants of chloroform, and in the 1800s, ether. I'll let Dr. Friedberg explain the history. And then the pain management industry really professionalized around the 60s. And now it shouldn't be a big deal going under for surgery. We definitely will want Dr. Friedberg also to talk about his experience with the Michael Jackson death and tragedy, because he was involved there. And that always perks people's ears, Michael Jackson, the iconic entertainer. And we'll also get into the opioid crisis because we've had several presenters on that issue over the years. There's a lot of demagoguery around that, hyperbole, and some downplayed causes like the drug war, how that exacerbates the whole problem. We might get into the whole issue of, what is pain? How does it apply to the chronic disease crisis, which those of us in Freedom believe is the real pandemic, the chronic disease epidemic that affects half the country. So Dr. Friedberg, Stanford educated, tell us about why the Goldilocks principle is very important for those of us engaged in healthcare entrepreneurship and advocacy to care about.
Well, thank you very much, Dr. Froman. I'd like to start with one of my favorite quotes is an ancient Chinese proverb that says, "The journey of 1,000 miles begins with a single step." And that first step for me was 30 years ago on March 26, 1992. This is my journey from pariah to prophet, and it's the story of 2 drugs, ketamine and fentanyl. Fentanyl is a very well-known name these days. We talked about the opioid crisis and fentanyl pouring over the border, and ketamine. Fentanyl is commonly used as a pre-medication before anesthesia, and is typically given as a 2 cc dose. It's 100 times more potent than morphine, and the potential for depressing your breathing is staggering. Ketamine, on the other hand, is a largely unused drug in 1992. It was unused because of its reputation for causing hallucinogens. It's a less potent hallucinogen than its parent compound, phencyclidine phosphate, angel dust, or it was marketed for a very brief time as the drug Serenil because patients looked very serene when they had it. It was also in 92, basically known as an animal or veterinary tranquilizer, a date rape drug, and a rave drug. So you can imagine things were not real warm and fuzzy when I stood up to talk about ketamine. So we have fentanyl associated with the opioid epidemic, to ketamine now being used for chronic pain and depression therapy. The emotional impact of uttering the word ketamine is not nearly what it was 30 years ago. It even appeared in Allure magazine in this past January issue. So this is a story of my passage from opioid inclusive anesthesia with fentanyl to opioid free anesthesia with ketamine. This is a journey from artful guessing using body weight and vital signs to determine dosages to scientific measurement with a brain monitor, a bispectral index brain monitor. This is my story. The first 15 years I practiced for what I believe was true. And that's the unspoken syllogism that we all learn, that surgery is painful, opioids are painkillers, and therefore all surgery requires opioids. Well, in 1983, we got the first pulse oximeter on the market, and it took 7 long years before the American Society of Anesthesiologists decided that this was a standard of care, that knowing what your patient's oxygen level was a really good thing on a beat by beat basis. This was a real-time monitor, and it took a long time, but they finally declared that as a station of care. In 1990 in Newport Beach, an otherwise healthy 35-year-old woman goes to her plastic surgeon's office for breast augmentation. There's only one pulse oximeter in the office because, again, there was no office accreditation at the time, and they didn't think they needed one. So she was over-medicated, she was unmonitored in an unwitnessed recovery room, and she experienced a fentanyl death, a fentanyl overdose death. It was a very tragic situation. It made the newspapers, and I heard about it because the fellow who came up from downstairs surgery center resuscitator was also part of the Hoag anesthesia department. So he presented the case and I knew about it. And the surgeon involved I had worked with for years in the earlier 80s at the hospital. In December of 1991, I attended a lecture, a plastic surgeon from Las Vegas, who talked about Valium and ketamine anesthesia. And he told us that Valium, if you gave the Valium first, you didn't have hallucinations from the ketamine, and the patients would lie perfectly still while you injected the local anesthesia. So that's what was known in 1992, that Valium blocks ketamine hallucinations, and that pain and postoperative nausea and vomiting, PONV, are the 2 persistent anesthesia problems of the day, and they were big in the literature. So I approached the surgeon that had this disaster in 1990 and said, I think I'd be better off giving your patients surgery, anesthesia for your surgery in the office. He says, well, you can use any drugs you like, just no opioids. So that was the origin of my odyssey into opioid-free anesthesia. I was left with very little alternative, and it was unknown at the time if propofol doses would block ketamine hallucinations just as well as Valium. It was seriously an unknown. So after my first 25 cases, I said, wow, this is fantastic. Nobody's hallucinating. Everybody's lying still, just like Vinnick said, the plastic surgeon, for the local anesthetic injection. And over the next 25 cases, I see, well, gosh, nobody's in pain when they wake up and nobody's nauseated or vomiting. And yet I've given no opioids. Now, up until this point in time, for the first 15 years, I was giving opioids because that's what I believe was necessary to prevent pain during surgery and hopefully mitigate pain after surgery. And here I've seen 50 consecutive patients who are pain-free. Unbelievable. I think this is the most fantastic experience. To this day, I'm still staggered at the concept. So in 1993, I give my first presentation. And I think because everybody's talking about pain and post-op nausea and vomiting, and I offer a solution, that people would be really, really interested. Instead, I got an excoriating reception, and I became instantly a pariah because, again, with the reputation that ketamine had at the time, date rape drug, animal tranquilizer, rave drug, what everybody knows, this is not a drug that you use on adults. So instant pariah. So I'm motivated at this point to publish and lecture and persist because I've seen a true experience. And people who are so-called experts were trying to say, no, Dr. Friedberg, you're wrong. Okay. So in 1993, I published that sleep doses indeed do prevent ketamine hallucinations. It was a peer-reviewed letter in the plastic surgery literature, but of course nobody in anesthesia reads the plastic surgery literature, and if they read it, they certainly wouldn't believe it based on the long-standing reputation of ketamine. So 3 years later, in 1996, the Food and Drug Administration approves a monitor called the bispectral index. It's a brain monitor, and it's designed to measure the effect of propofol and other sleep drugs like the inhalational drugs halothane and fluorine, sevoflurane. And from 1992 to 1997, of course, in the office, I'm giving proprietary expensive Diprovan, and the surgeons are loving the way the patients wake up. They're happy, they're not sick to their stomach, they're not hungover, but they're crying about the cost of the propofol. So I'm rolling out my Society for Office Anesthesiologists in 1997 in the spring, and I meet up with the Aspect Medical people who are marketing this product that is basically as a propofol monitor. And a processed EEG is what this monitor is, an electroencephalogram. But the problem with the processing is it takes 15 to 30 seconds to deliver the information, which is a little bit like trying to drive your car just looking in the rearview mirror. It's a great view of where you've been, but it's not telling you where you're going. And a year later, after struggling with the device, I finally took the salesman's suggestion and added the real-time electromyogram signal. The electromyogram is the EKG of the frontalis muscle. And this allows us to have real-time instantaneous information. Well, in 1999, I published an astounding 0.6 postoperative nausea and vomiting rate in a high-risk population without using any anti-nausea medicines, which is amazing, absolutely amazing. Christian Apfel is the guy who recognized this when he published his work in the New England Journal of Medicine, which said the 4 qualities that determine what happens to postoperative nausea and vomiting. Well, there you go. Bad Dr. Friedberg. Didn't silence the damn phone. Sorry about that. Okay. And in 2000, I published 30% less propofol when you're using BIS EMG monitoring versus using body weight and vital signs guessing. Now, along the way, in 2007, I don't know if you can see this well or not. This is the textbook I published. This is a very interesting textbook because the first textbook in the field, anesthesia and cosmetic surgery. That's where I made my reputation. And you can see here is a brain monitor. This is the first and only anesthesia textbook, by the way, with a brain monitor on the cover. There may be some in recent years, but I haven't seen any. It's also the first textbook to describe levels of sedation anesthesia with numbers instead of verbal descriptions. Okay. All right. The other interesting fact about this is Chapter 7 was written by the US military. And you would say, well, what is the US military writing a chapter in this book? It says, well, it turns out that they wrote the chapter Propofol Ketamine Beyond Cosmetic Surgery, Implications for Military Medicine and Mass Casualty Anesthesia. And along the way in the same year, I don't know if you can see this well or not, this is my US Congressional Award that I received for my work because the US military is using this approach for advanced field anesthesia, so they don't have to have an anesthesia machine and drag around large quantities H tanks for oxygen. 2 years later, Agoa Lee and et al. Published one anesthesia over medication death from over medication alone, independent of any comorbidities. And since I already know that you use 30% less drugs when you're measuring, I think that this is a really important moment. Unfortunately, the editors of Anesthesiology, the principal journal, didn't think it was an article of significance and didn't rate it as such. But that was the impetus for me to start my Goldilocks Anesthesia Foundation. And I called it Goldilocks as a shorthand because foolishly I assumed everybody knew the story of Goldilocks and the Three Bears, which is a shorthand for not too much and not too little, just the right amount. So if the number from your forehead from the brain monitor tells you how the individual is responding, you can't get too much or too little, only just the right amount. Well, it turns out Spanish speakers don't know this story by the name Goldilocks. They only know her by the name Ricitos de Oro, the golden haired one. So that made it a lot easier for a thing. By the way, the foundation is entirely self-funded. It's a 501c3, a nonprofit. Okay. As part of this project, I wrote and published this book. That's kind of what Dr. Friedberg looked like in 2009 after a 4-hour photo session with a Vogue magazine photographer. This is a patient information book. It is a free e-copy download from the website. We'll talk about that a little bit later. Also in 2009, okay, so here is the website, and it took me a long time to get a good logo for the website, but this was after several attempts. You can see the waves going over the brain, and the whole idea is to make brain monitoring the 21st century standard of care for major surgery. Right, and we scroll down here to the lower level. You can see that in the middle of the homepage, this is the thing that got to me, that yes, 365 deaths a year is a small number compared to 50 million patients anesthetized, but if that one of those deaths happens to be a friend or beloved family member, and they didn't have a brain monitor for a lousy $20 disposable sensor, that's pretty inexcusable. If you scroll down a little farther, you can see that there is the book that I wrote and published, going under. The download button is there. There's no request for your email, there's no cookies, and there's no contribution requested. I have been on television. A number of things revolved around the Michael Jackson story. A little farther down at the bottom, you can see again, anesthesia in cosmetic surgery. So I will show you that again, back to the screen, the main screen. This is my textbook, which was translated in 2009 in Portuguese. And I asked them, why Portuguese? And they said, very, Brazil, Portuguese, cosmetic surgery. The light went on. Okay. Now, along the way, things got even better. One of the things that's really important about publishing articles is that at least 50% of all articles published are never cited by a later author, never. Okay, so if only one author cites you, you're ahead of half the literature. My articles have been cited, by the way, in more than 200 later articles and in more than 50 anesthesia textbooks, including the Bible of Anesthesia, Miller's Anesthesia. This is one volume of a 2-volume set, and this is the 2010 book. Probably not going to be able to see this very well on the screen, but here is the reference to my 1999 paper. So I think that's kind of a big deal. Along the way, I get myself on national TV, in addition to a bunch of local TV, to talk about the book and the risks of anesthesia and trying to dispel fears of anesthesia with the information and getting over going under. So the TV show is called The Doctor's Show. It has half the viewing audience of Dr. Oz, and it's 2 million in the audience and 200 as a live performance. And they start the segment with the copy of the book. After that appearance, I thought a couple of hundred copies would be sold, might help defray the more than $100,000 I spent creating the foundation and the book, getting it published and all the other stuff. 6 copies were sold that week and another 4 copies the following week. So after this rather depressing experience, I decided to put the book on the website, the foundation website, as a free e-copy download. Along the way, of course, I've given away more than 7,500 hard copies of the book. I think it's very, very important for people to have this information. As my journey goes on in 2015, I will show you the Mandarin Chinese translation of my textbook. You see, it's the same book. Fortunately, I was working with a gentleman who spoke Mandarin, and he was an enthusiastic adopter of propofol ketamine, so he was able to proofread it and show me that it was actually a good translation. So most of the 26 years I've been doing opioid-free propofol ketamine, I've been trying to rehabilitate the reputation of ketamine, because it's very hard when even today, the residents, the trainees in anesthesia are being taught ketamine is, it's a safe drug. It supports breathing and circulation, but it causes bad dreams and high blood pressure and rapid heart rate. So what makes me a prophet? Well, folks like Dr. Froman give me a chance to talk about what I've done. And a prophet is somebody who says things that people don't want to hear, especially the national organizations of anesthesia, both the American Society of Anesthesiologists, the ASA, as well as the American Association of Nurse Anesthetists, the ANA. What do they not want to hear? They don't want to hear that measuring, like with a brain monitor, there's several others, but this happens to be the first one. Measuring is better than guessing. Gosh, that doesn't seem too difficult to grasp. And why does the ASA and ANA continue to aggressively resist the self-evident notion? Well, the story is that if you're using less drugs, the people who sell those drugs are not going to be very happy. Those are the drug makers. And it also turns out, not very apparent to the general public, is that the drug makers provide a lot of financial support. They call it corporate sponsorship. I call it pay to play, whatever you want to call it. Money is flowing from the drug makers to these organizations, and no organization is going to willingly commit or risk financial suicide by saying things or endorsing things that don't support the efforts of their corporate sponsorship. Okay, what else don't they want to hear? Well, the biggie with the ketamine is that when I saw those 50 patients wake up, those first 50 patients wake up not in pain, despite not using opioids, I said, wow, the only reason people must be having pain after surgery is they were having pain during surgery. There's nothing more fundamental to the concept of giving anesthesia than the amelioration of pain during surgery. And here comes Dr. Friedberg along trying to upset the whole darn apple cart, saying, wait a second, if you don't give that 50 milligrams of ketamine 2 to 3 minutes before incision, you're letting the surgeon violate the patient's outer membrane, the skin. This is the only barrier between the outside world of danger and the inner protected world of self. And it's very simple to do. Anybody can do it. People don't want to hear that message. They want to believe the reason that people have pain after surgery is they finally woke up and realized that it had a painful experience. Well, it doesn't really fit well with the idea of not giving opioids and not having pain after surgery, or certainly to a very limited extent, needing opioids for pain. So what does that 50 milligrams do? It prevents the patient's brain from recognizing bodily invasion, and it prevents the inner pain fibers from going on high alert. Using this, you virtually eliminate the need for postoperative opioids. And if you don't need the opioids, it's very hard to become addicted to something you don't take. Also, as one of my early converts in England said, if you want people to stop throwing up, stop giving them drugs that make them sick to their stomach. Pretty self-evident. Along the way, I've coined the term Friedberg's triad, which is measure the brain, preempt the pain, emetic drugs abstain. And this is a very powerful, simple tool to help colleagues in anesthesia understand what do they have to do to get better outcomes. The key thing is it becomes a very cost-effective way to give anesthesia. And you say, well, why should it be cost-effective? I said, well, you're eliminating the outliers, the people that really, the average, so-called average patients, of which there really are very few. You don't have these problems. If you're measuring how much each patient gives and you don't give too much or too little, you get rid of those type of patients who are under-medicated and have a miserable time when they wake up, or over-medicated who have a very difficult time waking up and take a long time to be ready to go home to discharge. You eliminate the unanticipated pain and postoperative nausea and vomiting admissions. So what are my outcomes that I've been talking about? Over 26 years, more than 6,000 opioid-free outpatients in an office-based setting of more than 100 different surgeons, both plastic and cosmetic surgeons. Also in 20 years with just the brain monitor and the EMG. Well, the overwhelming majority of these patients are discharged to home within an hour or less, and they don't need professional aftercare givers when they get home. There are no opioid addicts or opioid overdoses. All of these patients had commercial insurance, and so if they needed to be admitted, the lack of insurance wouldn't be a problem. But over that period of time, 26 years, more than 6,000 patients, not a single patient required hospitalization for pain or post-op nausea and vomiting. And as everybody's favorite group, the Grateful Dead, say, this has been a long, strange trip. I was going to show a few PowerPoint slides, but I don't have the ability. I just want to go here to show one of the things I'd like to talk about is what we call ORADs, or opioid-related adverse drug effects. To say nothing, the main thing you want to avoid is having a patient found dead in bed from respiratory depression, obstruction, aspiration, vomiting, and inhaling the emesis. It's sedation, prolonged somnolence, brain fog, ileus, constipation, urinary retention, of course, nausea and vomiting. There was a great study that came out by Kessler in 2013, who looked at the cost and quality implications of opioid-based post-surgical pain control using administrative claims data from a large health system, opioid-related adverse effects and their impact on clinical and economic outcomes. There was a 55% increased length of stay, 47% higher costs, 36% increased 30-day readmission risk, and a 3.5 times higher mortality. If that's not a potent endorsement of opioid-free, I'm not sure what is. Trying to find the Frauenknecht study, not finding that, but at Frauenknecht et al. In 2019 published a meta-analysis of 23 studies in 1,304 patients comparing opioid-inclusive anesthesia, that means you gave fentanyl or whatever during the case, to opioid-free anesthesia. Surprise, surprise, giving opioids during anesthesia does not prevent postoperative pain, unlike my experience of 26 years of not giving opioids and using pre-incisional ketamine, which does prevent postoperative pain. Okay, and guess what else they found in this study? Using opioids increases postoperative nausea and vomiting, which is patients' #1 concern. They don't want to throw up because they expect to have some pain after surgery, but they don't expect to be sick to their stomach. And the other thing about opioid-related vomiting is that it's a recurring thing, kind of like motion sickness. It's not just once and done. It's just over and over and over. So no one actually dies from postoperative nausea and vomiting. They only wish they were dead. Okay. Last but not least, I will tell you the quote from 2018, the fellow who was then the American Society of Anesthesiologists treasurer. He's in line to become president next. I believe it's next year. His name is Mike Champeau. And he wrote to me, he says, Barry, you were just 25 years ahead of your colleagues. I'm hearing more and more talk about opioid-free anesthesia, even at the ASA. So I hope you've gotten an idea that using the brain monitor and using opioid-free anesthesia is a much better way to go than traditional types of anesthesia. But again, that's what makes for a profit. People don't want to hear in general what you have to say. And I'm very deeply grateful for Dr. Froman for giving me a chance. I didn't mention the Michael Jackson story. When that came out, I was originally asked to be the first expert witness to defend Conrad Murray. And so Mr. Gallagher got me up to his office here in Glendale, and he was trying to explain to me what a great physician this Conrad Murray was. And he said, Conrad Murray is such a great cardiologist. When he does a cardioversion, he doesn't even start an intravenous. He just puts the propofol straight in the vein. And my eyes kind of got big, and I said, well, I'm not sure I can find the right word in the English language to describe how reckless, how cavalier that kind of behavior is. There's not a chance in the world that I could possibly defend somebody who thinks that's a normal way to go about giving propofol. Just crazy. So I demurred, and then they called Paul White, who took the deal. That's the story with Michael Jackson. It was a very sad thing. As crazy as it was to give him propofol for sleep, it could have very easily been done safely had Conrad Murray just used one of those baby monitors that listens for the baby breathing to prevent sudden infant death syndrome. He could have been out in the hallway as he was talking to his girlfriend and listening in the other ear to the sound of Michael Jackson breathing. And when Michael stopped, he could have walked in, picked up his chin, opened his airway, and Michael would have been alive to go ahead and give his concert tour. So with that, I'm going to turn it over. I don't know how long we've been talking, but I think probably enough. Be happy to take questions and do my best to try to answer them.
Thanks, Dr. Friedberg. And thank you for calling me doctor. I did get a master's to teach history, but I'm not a doctor. Forbes featured my company for revolutionizing the health payment world. You know, we upgrade folks away from insurance, which limits your choice. They use networks, and we make cash patients. And that's kind of the reason we've been having the show for every week for 3 years, is how do we help the patient shop on quality? So we've had a lot of ambulatory surgical centers, a lot of direct pay specialists, and a lot of innovators like you. And I have a lot of questions. And folks, if you have questions, just click the raise hand icon and we'll get your questions asked. Jim, you have your hand up. Before you do, why was Michael Jackson on propofol or getting sleep help in the first place? Was he sick? What was the story? I get the fact that, you know, direct injection probably was a very, very terminal decision, so to speak. Go ahead.
Michael Jackson had terrible problems sleeping at night. And it was a rather, in other words, propofol for a majority of people over the years has given us a single dose to replace our old friends pentothal or thiopental. Single dose, go to sleep, and then they have inhalational anesthesia provided on top of that. So the idea of giving propofol continuously was something that I pioneered in 1992. And I guess they heard about me at some point and thought that I might be able to help out. So he was receiving continuous propofol through the night to keep him asleep. It wasn't a single dose to get him asleep. It was an infusion he was getting. And like I said, it could have, as crazy as it was to do such a thing, it completely, what do they call that, an off-label use of the drug. It could have been done safely. And the thing that was amazing to me when I looked over the situation is it took 6 weeks to be able of doing it this way to actually find enough, that Michael got enough propofol to cause him to lose his airway. His jaw went slack, his tongue dropped on the back of his throat, and there was nobody watching or monitoring him to come in and just lift his chin off the back of, up and take his tongue off the back of the throat and open his airway. I mean, it wasn't a mystery why he died. It wasn't a mystery how it could have been prevented, but you know, it was clearly very off-label use.
So one more thing, Philip, before Jim. So there are people that need IVs to stay asleep all night long like that? That's a
only
thing?
if you're Michael Jackson. That's definitely an outlier.
That's insane. But I guess
Yes, of course.
But I learn new stuff about healthcare every week.
By the way, all of my patients in the 26 years of the time I was talking to were cash patients. They were all elective cosmetic surgery patients, which is perhaps how you may have found me in the first place, interfacing with your work. And that's why I point out that they all had commercial insurance. So if they had pain or nausea and vomiting that would require hospitalization, the lack of insurance wasn't an obstacle to them being admitted. So it's a very powerful statement that if you conduct surgery and anesthesia with this paradigm, these are the outcomes that you can get. And with the brain monitor, it's a reproducible. It's not a question of, it's no longer an art, it's a scientific fact. But then again, measuring is better than guessing.
Indeed. Jim?
Thank you. Hey, great presentation. Loved it. Having been in surgery a number of times myself, I get it.
The impressive thing is that you stayed awake. You can now tell your friends, you heard an anesthesiologist, you listened to an anesthesiologist, and you stayed awake. That's not what we usually do.
And it's funny. So before my question, I just want to throw out one thing. So if I go into surgery again, I would love to make sure that I'm getting those drugs, just like you're talking about with the brain monitor.
Right.
That would be my second. My first option might be, and it depends on the surgery, I suppose. You probably know this, years ago when Congressman Berkeley Bedell went to China and was witnessing, he was in a hospital and they were doing surgery on somebody's stomach. And they had a curtain up like behind the woman, right? And they were using acupuncture.
Exactly.
And they felt no pain. In fact, the patient was awake while they did the surgery so they could talk to them. And he was told, I think the price, it was pretty inexpensive. Nothing. It's nothing. So obviously that hasn't been adopted here. I don't know if there's any reason why, or could that ever be, but probably, as you're saying, with the drug cartel, it's not going to happen. But let me go back to my actual two questions. Is one, is this applicable outside of cosmetic surgery for anything? And the second one is, for anybody looking that's going to go and have a surgical procedure, is there a network? Do you have a list of names or an index on your site, for example, so I could find an anesthesiologist or a CRNA that I'm comfortable with or whatever?
First of all, it's applicable to any time that you have to have surgery. As a medical student in 1972, I first became aware of acupuncture. I was very excited about the idea. And then I came to learn that it's effective in about 40% of people. The problem is, like hypnosis, is very hard to predict which 40%. The other thing is that once the Chinese were able to, I think it was Nixon's détente, once the Chinese were able to get access to Western medications, the use of acupuncture declined precipitously. It still can be used. It's a completely different social and economic environment there. It's a much greater trust between physician and patients, and Asians have, in particular, a very different approach to the idea of pain. It's viewed as a normal part of life, as opposed to our perception that it's something you really don't want. Okay, the idea of a network would be wonderful. I've toyed with the idea. It's very, very difficult. The reason I wrote the book was to empower patients. And typically what happens when you ask your anesthesiologist, you will use a brain monitor, right? That you get the pushback, oh, we don't need that. Your response is, with all respect, sir or ma'am, it's not your needs I'm concerned with. That's your parry and repost. It's very, very difficult. The other thing is that if you want to speak to your anesthesiologist or nurse anesthetist, they're usually not assigned to the night before surgery. So what you need to do is ask your surgeon or his scheduling person, who do they call when they want to schedule surgery? You want to ask that person, the scheduling person at the other end, who Dr. X typically works with, and of those 3 or 4 or whatever people he usually works with, who routinely uses a brain monitor? That's the person I want. So you don't have to have that discussion on the morning of surgery while you're lying on the gurney, already anxious about everything else. But really, the fear of anesthesia is one of the reasons I was motivated to write the book. I had 2 horrific anesthetics before I became a medical student. I was suffocated into unconsciousness with open drop ether as a 4-year-old child for my tonsils. And then to make matters worse, when I was 19 and had my 4 third molars extracted, I woke up in recovery room and couldn't breathe. And that's when I tell people I only lost enough brain cells to become an anesthesiologist. And if I'd lost a few more, I could have been a surgeon.
Thank you.
You're welcome.
That seems, Jim, a project for us network-wise.
Yeah.
This is kind of a blockbuster, Dr. Friedberg. People should be asking for brain monitored anesthesia with, what is the full request? Brain monitoring, ketamine, or how do you phrase the request?
Well, I call the ketamine, typically all medicines in anesthesia are given by per body weight. And ketamine is a very peculiar medicine in that it doesn't seem to matter how much you weigh or how old you are, young you are. 50 milligrams is a unitary dose, which is another thing that a prophet would say, and people would push back and say, no, it can't be. So, well, I've used it on people as weighing as little as 30 kilograms to as much as 145 kilograms, people as young as 7 and as old as 94, and they get the same response. They lie still to noxious stimulation, whether that's local anesthetic injections, incisions, or trocar punctures for endoscopic procedures. So it's the nifty 50. That's what I call it. And so when I had my hip done last year, it was done as an outpatient, my left hip replacement. We had a short-acting spinal. We had brain-monitored propofol and 50 milligrams ketamine 3 minutes before incision. to make sure that those critical receptors in the midbrain block all the information. See, when you have a regional anesthetic like a spinal, yes, it's true that all the skin fibers below the level of the block are blocked. The trouble is the other unblocked fibers are still communicating with the brain. And if you don't take all of that out of the equation, then the brain realizes that the body's been invaded. And now the internal pain fibers go up on high alert. Whereas the other way, which is what I've been doing for 26 years, it's a complete illusion to the brain. The common term is dissociation. You dissociate the brain from the body. Sounds a little scary, but it's only a transitory issue for the worst possible thing that happens is that the brain noses. The trouble is when you anesthetize or you sedate the patient, the brain can't tell the difference between the malevolent intent of a mugger's knife and the therapeutic intent of the surgeon's scalpel. It only knows one thing: invasion. We've been invaded. Not good. So when you take that out of the equation, everything you thought you knew about patients waking up after anesthesia changes, and it's not subtle. What I didn't tell you about the lack of nausea and vomiting and pain when patients wake up is the way their face looked. The face doesn't look like somebody who's received surgical trauma. It looks like it looked when it went to sleep. And it's like, it's an OMG kind of a thing. How can this be? I've had many anesthesia colleagues come and watch me do an abdominoplasty, a tummy tuck, with this exact technique, where there's 150 milligram dose. They put the local anesthesia, the tumescent fluid in the belly, the dissection and the surgery is done, and the patient's breathing room air and doesn't need even an artificial airway or supplemental oxygen. And at the end of the case, they always ask the same question. They say, "That was great, Dr. Friedberg. What was the trick? What did you give the patient that you didn't show us?" I said, "Well, you see, there's nothing up my sleeves. There's very little between my ears. There's a couple of syringes on the back table. Well, the problem is that you have cognitive dissonance. Your brain cannot accept what your eyes just showed you because you, like me, were taught abdominoplasty is a major invasive procedure and it requires profound muscle relaxation, which it does not. So you're constantly looking at things that you know are not true, but they are true. And so the easiest way to say is to deal with it is, what was the trick? There's no trick.
This is amazing. I'll mention also for cash doctors, not only do we have the cost of insurance via sharing, which has no networks, but we've also started to sell the money doubling cash account for those patients who hem and haw about affording the cash price. So it goes from $2,500 up to $60,000. So depending on the expected out-of-pocket cost, we can cut that in half over 3 years. So get back to me, anyone who wants information on getting the cash help. This is shocking. That's going to be tough to find an anesthesiologist that's going to achieve all the goals you mentioned. That gets to a 30,000 foot problem, I guess, with medical education and, of course, the government's top-down approach to medicine with these standards and the risk to doctors who are mavericks from the licensing boards. You mentioned at the beginning the art of your approach, and medicine is an art, not just a science. I'm sure you thought about this. If we're going to talk to the medical students, how do you reinstate that sense of purpose via art and creativity in medicine so that we can have future Dr. Friedbergs?
Well, I'm sure that many people have said it's a good thing they threw the mold away when they made me. I continue to be active on LinkedIn and continue to provide education and support. How to get to the medical students? Well, it's very hard to get to them for sure. I have a list of anesthesiologists who are the educational directors of the anesthesia residency training programs, and I email them updates regularly. So they're not for lack of knowing that I exist. What they are a lack of is motivation, because if the national organization doesn't say, the brain is the target of anesthetics, and we've had the ability to directly measure brain effect for more than 20 years, why are they going to try to help people understand that? The other interesting thing I found with brain monitoring is, without beating numbers too much, is that to get to a moderate or deep level of sedation numerically, most of the patients take 25 to 50 micrograms per kilogram per minute of propofol. Sensitive patients can take as little as 2, and resistant patients can take as much as 200 mics per kilo. So there's 100-fold variation in my own practice of how much variation there is. And if you're not measuring, you're going to always over or under medicate the percentage of people who are outside the limits of the bell curve. And I wish I knew the answer to medical students and ketamine, because they're still teaching that to the medical students and the residents, as if nobody ever published anything about how you use ketamine and why you want to use ketamine as opposed to opioids. Remember, there's an awful lot of money tied up in the sale of fentanyl and the obligatory anti-nausea medicines, as well as the propofol. Even though it's generic, it's still a
Before Jim
source of
answers,
Yeah.
before Jim, you answer your question, let me follow up. The pushback on opioids. We mentioned the traditional healing sources over the past 1,000 years, mainly willowbark and the poppy plant. It's in the Egyptian myths from 2,000 years ago. Do you have an idea or a thought on the drug war? Over the years, our opioid defenders have said, yeah, we can talk about the pros and cons of opioids, but we have to acknowledge the elephant in the room, which is the drug wars, squeezing of the balloon into some illegal fentanyl traced heroin from the streets, when pain patients are arbitrarily limited from political decisions on pain meds. Do you have a comment on the drug war kind of exacerbating the whole opioid crisis? And then Jim, yeah.
Well, again, we get back to the idea is that the reason people have these issues after surgery is they were allowed to have pain during surgery. They didn't get the miracle of the pre-incision ketamine. I mean, one of my colleagues at Main Street Surgical Center in Orange, California, has a 5-room surgery center. He's retired now, and he's a dear friend of mine. I thought I had convinced him to stop giving the 2nd-generation Valium along with the Versed and the fentanyl, but he kept doing that. The only thing he changed was he was using the brain monitor and giving 50 milligrams of ketamine 3 minutes before incision. And the other fellows from the neighboring hospital who were staffing the other 4 rooms kept asking him, why do your patients look so much better in recovery than mine? And he explained to them about the brain monitor and the nifty 50 milligrams of ketamine. And so they started doing it, more and more people. So at least in that center and that hospital, more of them are doing it. It's a very slow process. It's very difficult to get people to change. There's an old expression that started off at Harvard, but it's malleable to anybody you want to talk about, is you can always tell an anesthesiologist. You just can't tell them very much.
Jim.
Okay. So Charlie, you mentioned risk. Well, let me go back. So for patients, let's say hip surgery.
Yes.
I want to call, or somebody wants to call their or the surgeon or anesthesiologist and say, look, this is what I'd like you to do. This is what, or can you, I'm comfortable with it. Are they in a bind? Is there any risk to them, their licenses, anything like that, if they go ahead with that?
There's nothing they would be criticized for. You can't be criticized for using an FDA approved device like the Biz monitor or the SedLine or I forget the other name of the Entropy. There's at least 3 of them out there. So it's not like, and most hospitals have these devices. It's not like somebody has to go out and buy it. The so-called objection is the $20 disposable sensor that you need to use, which is a ridiculous, objection for $20, right?
Yeah.
And there's the ketamine has been around since 1972, and nobody's going to take your license or criticizing you, especially if you're using 50 milligrams. It's not a very big dose. They may ask you, why did you not give it on a per milligram per kilogram basis? But they're not going to. There's no real risk. The real risk is trying to get that person who's going to administer the anesthesia to say, I'd really like this. By the way, there's a fair chance that many of the people that you would ask may have heard of me because I haven't gone away. I've been very persistent about trying to get this message across that it's not that difficult to do better for patients.
Right.
And
Well-
hopefully that's helpful.
So we've been hearing a lot from doctors that pushback, a lot of pushback from Medicare. So if they're trying to use procedures or things that Medicare doesn't approve, they don't get reimbursed, whatever the problem is, or they'll come after them. I've heard of things. Does that fit in here at all, or you don't think that's a problem?
No, there's nothing off-label about any of
Okay.
this. So
Okay.
there's no reason that they may not pay for the $20 sensor, but in a system, I don't think $20 is really a serious
No.
issue.
Yeah. Okay, great. Thank you.
You mentioned the pay-to-play dynamic leading towards more use of opioids and resistance to trying possibly more effective means like you're showing. A lot of folks, especially out of the COVID hysteria, are talking about a counterattack on conflicts of interest. Too many members of the cartel are funded by pharma and biotech, and a lot of folks are very angry, a lot of frontline doctors especially. What comments do you have about a conflict of interest campaign so that whoever you're dealing with, the extent to which they're not independent? They are conflicted possibly because of grants or funding bonuses from pharma and biotech.
Well, the main thing you have to understand about the money that pharma provides is it never goes to individual doctors. I mean, yes, they fund certain research projects if they have a drug that they're trying to push through. But in terms of the day-to-day thing, it's not like the drug detail salesman comes to your primary care guy's office and gives them, 2 tickets to the ball game. The money goes to the national organization. And as I said before, no national organization will willingly risk financial support from its benefactors. So that's where the big pushback is. The reason, I mean, it couldn't be more obvious why you want to measure the brain, right? I mean, nobody would give a blood pressure medicine and fail to measure the blood pressure response. And yet millions of patients receive brain medications, anesthetics every day without the benefit of brain monitoring. I will say this though, one of the nice things about the Hoag orthopedic unit over in Irvine, California, is that it's all joint replacements. It's a single floor. It's an independent entity. It's not part of the Hoag hospital situation. It's a physician-owned entity. And they do a very, very nice job of taking care of patients. All the patients routinely receive brain monitoring, as do all the open heart patients. So my question is, since our aging population is a bigger and bigger portion of the surgical population, why in the heck aren't we measuring these people? One of the problems we have, in addition to prolonged emergence, is brain fog. And I can't tell you that all brain fog after surgery is going to be eliminated by measuring what you're medicating, but I can tell you it's kind of like hoofbeats and horses. If you're routinely over medicating, and for the 20 years I didn't have the brain monitor, I routinely gave more than I thought was necessary for fear of not giving enough. Again, back to the Goldilocks thing. And now that you can measure directly, so one of the things I coined was minimally invasive anesthesia for minimally invasive surgery. I'm trying to convince one of my colleagues the virtues of using less drugs. He says, but Barry, you don't understand. The more drugs I give, the better I feel. I said, well, what about the patient? So it's a real challenge to break through. You go into any operating room and on the back table, the anesthesiologist's workplace, there's like between 8 and 15 syringes. You go to my operating room and there's like 3 or 4 syringes. People say, how can you give an anesthetic with these few syringes? Watch, but it's very, very difficult. We're trained in complexity in anesthesia. We're trained to learn dozens and dozens of drugs. And therefore the obvious conclusion is must need to use a lot of drugs to give a good anesthetic.
Well, let me ask you about that. If you're the anesthesiologist for all these surgeons and they see the great outcomes from partnering with you, it would seem in a market that word would get around, your reputation would lead to more business, more surgeons, et cetera, compounds. Has that happened?
Not really. You would think that this would be a great marketing tool for surgeons in a cash business, but it turns out that anything the surgeon does to promote the anesthetic detracts from his greatness as a surgeon. So although what you, oh yeah, that's how they feel. They don't want to distract from that. And these are fragile egos we're talking about. And yes, you would think that was, I never had problem having work. I mean, I always had work. I worked as much as I wanted to work, but I never got to the place where I had so much work I couldn't handle it. Yeah, it's an excellent question. And you would think that at some point, people would get onto the idea that, wow, if we have patients who are doing great, why don't we talk about this in our marketing program? Our patients don't throw up. Our patients don't have pain that needs narcotics. If you don't have narcotic needing pain, there's not much chance you're going to get addicted to something you never take. Our patients wake up bright-eyed and bushy-tailed. If I had my clips available, I could show you how the 4-hour abdominoplasty patient woke up, who was very typical. It's an incredible thing. So I'd be happy to help you in any way that I can, but I'm doing what I can do as a one-man venture. And I thank you again for your willingness to have me tell my story.
Maybe through our Wildcats Appointments app, Kelly Webb's exclusive surgeries chain of 2,000 surgeons in ASCs and underused hospitals. Maybe we could work indirectly through that or some other network. I see an opportunity here, Barry. We're running out of time. I mean, if you want to comment also on all the chronic patients out there who are on opioids or NSAIDs, which have their own side effects. A lot of them didn't get on those from surgery, but there's a lot of people using them for pain. Do you have any comment on that? Because they're not going to see you in the surgeries room, but they're suffering.
There are ketamine clinics, which are basically cash only because insurance doesn't pay for it. Ketamine clinics that are offering ketamine infusion therapy. Typically, it's a 0.5 milligram per kilogram in a diluted solution over 45 minutes. One of my colleagues says, yeah, but I like your nifty 50 better. 50 milligrams diluted over enough solution dripped in over 45 minutes to break the cycle. It's like rebooting your computer. That's the reason they're using it for chronic pain and refractory depression and to deal with people who are suicidal. It's not something you want to take at home. Although I saw something about that being offered someplace. You want to be around somebody else to support you because like all potentially hallucinogenic agents, the ketamine experience is directly affected by your mood, your state of mind when you go in. And so if you're in a place with a ketamine clinic where they say, we're here to support you, this is a kind experience. And it's really, I've not been involved personally, but I have friends who run ketamine clinics of Los Angeles, for instance, who are doing very well and doing great things for patients in chronic pain, whether it's been for surgery or non-surgical situations. Hope that helps.
It does. You've commented well on a lot of different issues, and we're out of time. Thank you for the Grateful Dead reference. A lot of us.
It's been a long, strange trip, that's for sure.
A lot of us have experienced shows in life-changing ways, hopefully for the better. And any final words that folks can reach you?
Well, GoldilocksFoundation.org is always there. I'm only an email or text message away. Happy to support people. Again, I think probably the best thing people can do is to download their free copy and have the information here dispel the anesthesia fears and bad experiences you've had in the past. The clue about making sure you try to get to the person who does the surgery scheduling, because invariably there's always going to be one anesthesiologist in that surgeon's choice who routinely uses the brain monitor, and then all you have to convince them of is to give you 50 milligrams of ketamine 3 minutes before the incision. And usually, with ketamine being more and more prevalent now, it's not so scary as it was 20 years ago, 30 years ago. I mean, it's really, it's nice to not be a pariah anymore. Nobody likes to be a pariah when you've got obviously good outcomes and better than the outcomes other people are talking about. So again, I thank you and very happy to contribute to your efforts.
So what about your wealth? If your money could actually talk to you, would you listen to it? Well, with the DNA Network Academy, your money actually can talk to you, and it's going to tell you just what it told this client. This family had over 24 debts, mortgages, car loans, the works. They were on track to take 20 years to pay it all off and instead did it in 8.5. Plus, they did it without refinancing, making more money, or even changing their lifestyle. So find out for yourself with a free analysis that is completely confidential. No personal information, no social security numbers, no credit checks, none of that nonsense. But what is exciting is that the outcome of that report you receive is a guaranteed outcome for you. To get that report, head on over to bit.ly/debt to wealth. You will arrive at this simple form. Fill it in as simple as lender number 1 and credit card number 2. What really matters is the accuracy of your numbers. You'll be able to see that if instead of 20 years or whatever your number is, that you may actually be out of debt and on your way to wealth in as little as 6.3 years like this client.